Very good morning to esteemed dignitaries, senior faculties, and my dear colleagues and residents. Today's CCR is on time is brain. So today we will see how the time is saved, how brain is saved, and how the life is saved. Because every minute counts in the Department of Neurointervention. Wishing you a very, very happy New Year 2026. So Department of Interventional Neurology was inaugurated on 11 December 2025, 4th floor SRCC with the esteemed presence of Emeritus Chairperson Sir, and Vice Chancellor, Pro Vice Chancellor, Director Sir, Principal Sir, and esteemed faculties of our institution. These are the few glimpses of the inaugurations, and this is our biplane cath lab which was inaugurated on the day of 11 December. It was very fortunate day for us that we are having dedicated neurointerventional angiography shoot to do the procedures in the Department of Intervention. Faculty myself, Dr. Shobhit Gupta. I did my DM in Intervention Neuroradiology from All India Institute of Medical Sciences, New Delhi, and I'm having experience of dedicated neurointervention procedures since last 10 years, and I'm working as a professor and head of department of this institution in this department. Currently, DM courses in intervention neuroradiology in India is going on in central institutes like AIIMS New Delhi, PGI Chandigarh, Sri Chitra Trivandrum, NIMHANS Bengaluru, JIPMER Pondicherry, and in the private institution only in the SRMC Chennai in the South India. We are having planned to DM course in MGUMST to Jaipur, so it would be the first center in North India and second in India among the first private institution to start this course for the intervention neurology. Why the biplane has been chosen for the neurointervention? Single plane is already there. Why it is need? Because it is very important to do the complex neurovascular cases as well as radiation, and in view of the contrast exposure, it is very helpful for the patient as well as the doctor or operator. We can do the faster, safer, and more precise treatment. I will show this advantage after the case discussion. Intervention neuroradiology, also called the intervention neurology, endovascular neurosurgery or neurointervention surgery in the all over the world regarding the name of the procedures. What it is actually? It is a minimal invasive subspecialty of the neurosciences where we are dealing with the catheters and imaging to treat the brain, spine, and neck disorders related to the neurovascular through the blood vessels without opening surgery, and it will lead to the faster recovery, especially in the stroke, aneurysms, and vascular malformations. Little bit history. In the 1991, Guglielmi started the coiling. You can see these are the coil first used in the 1991, and the 20th century, the complex aneurysm cases become the alternative to the surgical clipping in the advancement of this coiling. And this time the ISET trial, International Subarachnoid Aneurysmal Trial, came, which was showing that it is an alternative to the clipping in the cases. And boom of the neurointervention came in the 2015, where the multiple clinical trials came in 2015. They are saying that if you will do the neurointervention mechanical thrombectomy in the acute ischemic stroke, it will become the gold standard care. If you are not offering the neurointervention mechanical thrombectomy in the acute ischemic stroke due to the large vessel occlusion, it is not advisable nowadays. It is a gold standard of care. So these are the few procedures which we are doing in the neurointervention department: mechanical thrombectomy, intracranial angioplasty and stenting, and carotid stenting. For the aneurysms and the AVMs, we are doing coiling, flow diverter, stenting, embolization. And recently, now 2 to 3 years before, the recurrent chronic subdural hematomas, where the burr-hole surgery is the gold standard treatment. Because of the meningeal inflammation, the recurrence rate is high, so the middle meningeal artery embolization becomes a treatment of choice in these cases. Sometimes in the idiopathic intracranial hypertension, where the medical treatment is refractory and transverse sinuses are the cause for that, the venous sinus stenting has become a treatment, as well as the DSN, periaortic embolization, and the other cases. So from the starting to September to December 25, we are having around 35 to 40 OPDs in the average view, and these are the procedures which we are doing we have done from the September 34, 41, 37, and last month after the dedicated cath lab came, it became the 58. Average neurointerventions in the all over the world or in India, it is 3 to 4 therapeutic or 3 to 6 therapeutic in a month. But DSA including it is 15 to 20. We are crossing that. We are doing 13, 10, 9 and 30 therapeutic neurointervention. It is a high volume center in this North India center from the MGUMST Jaipur. From this 4 months, we did around 170 cases. Out of that, 107 cases are the therapeutic cases. And we are doing not only the DSA, we are doing all types of the neurointervention with the vast majority of cases in this case. So what is the mechanical thrombectomy? We are taking microcatheter and a stent retriever to this clot, and we are pulling it out from the brain and opening the vessel. It is called the mechanical thrombectomy. We are putting that thing. Sometimes, like this heart attack, we are doing the coronary angioplasty. Like the brain, intracranial blood vessels can cause the recurrent stroke despite the best medical management. Then we are putting the stent and patient can be treated, just like the carotid stenting as well. In cases of the ischemic stroke, after that hemorrhagic stroke, you can see the subarachnoid hemorrhage can be treated surgical clipping, and alternate to this is coiling, stent assisted coiling and flow diverters are the treatment of choice. These are the few cases which we have done in the MGUMST. Cranial dural fistula, you can see the fistula over here. We have treated and it is completely gone. Cranial AVMs due to the brain hemorrhage. This is a rare case of the brain hemorrhage where we have treated with the coiling as well as the embolization. Epistaxis due to the ruptured aneurysm, we can treat it. Carotid cavernous fistula. And spinal dural AB malformations due to this fistula, patient develop bilateral lower limb weakness and we can treat with this one. These are the few media coverages CME with the immense support of the management. As the MGUMST family, we have done good work over here. And now I would like to call Dr. Pavni Agrawal for discussion the case.
Good morning, respected dignitaries, all senior faculty members and my colleagues. My case is that of a 43-year-old right-handed male who initially presented to the cardiology department with acute onset chest pain and heaviness and was eventually diagnosed as having anterior wall MI. He underwent primary PTCA to the LAD and RCA with successful recanalization and he was stabilized. During admission, the patient was found to have newly diagnosed type 2 diabetes mellitus with a very poor glycemic control, adding a significant vascular risk factor. He was started on dual antiplatelet therapy with aspirin and ticagrelor along with high-dose statins. His 2D echocardiography showed RWMAs, but there was no atrial fibrillation, no LA or LV clot. After admission on 28th of October, the patient was stabilized and was planned for discharge on 1st of November. When around 11:30 p.m., he developed sudden onset left-sided weakness along with slurring of speech and altered sensorium in the form of confusion and drowsiness. The hyperacute nature of focal neurological deficits occurring in the hospital immediately raised concern and a neurology referral was given. The patient was attended promptly. On evaluation, the patient was hypertensive, normocardic, and although he had a significantly elevated RBS, but no immediate metabolic explanation was there that could fully account for the focal deficits. On doing a detailed neurological examination, his GCS was found to be E3V2M5, which is a low GCS. And in view of this low GCS, his further neurological examination consisting of motor examination, sensory and cerebellar examination could not be done. A brief cardiovascular, respiratory and perabdominal examination showed no abnormality. So, in a 43-year-old male with recent cardiac event with poorly controlled diabetes who presented with a hyperacute event with neurological deficits and a poor GCS, what could be the possibilities in such a patient? Anybody from the audience? Thank you. Thank you, Dr. Kunal. So, given the hyperacute onset of the focal deficits in a patient with strong vascular risk profile, vascular causes were prioritized. Post-ictal state, metabolic or toxic causes and structural compressive causes were considered but were quickly deprioritized based on clinical context. So it is estimated that nearly 1.9 million neurons are lost every minute during an untreated ischemic stroke, which reinstates the fact that time is brain. Once an acute stroke was suspected, the focus is on rapid imaging, parallel decision making, and early coordination with the stroke team. So for our patient, in view of altered sensorium and unresponsiveness, a code blue was activated without any delay. Given the risk of aspiration and need for controlled imaging and intervention, endotracheal intubation was done early to secure the airway. Simultaneously, as per the stroke protocol, the patient was shifted for an urgent NCCT head and the neurointervention team was immediately informed. Now I would like to call Dr. Shobhit Gupta from the Department of Radiodiagnosis to discuss the neuroimaging of the patient.
So I'd like to compliment you and your department for a crisp case presentation. I particularly like the differential diagnosis, and then you did not say ruled out, you said deprioritized. I really like that word, right?
Thank you, Dr. Pavni. Good morning, respected dignitaries, senior faculty, seniors and colleagues. So I will be presenting the radiological findings of the case. So the patient was referred to our department for NCCT head at around 12:15 am in the night on 2nd of November with the history of hyperacute neurological deficit in form of left-sided weakness, dysarthria and altered sensorium. So NCCT head was done at 12:15 am in the night on 2nd of November, and the findings of which are as follows. This is the axial cut of the NCCT head soft tissue window at the level of pons. As compared to the normal left side, we can see hypodense area in the right cerebellar hemisphere and the middle cerebellar peduncles with loss of normal gray-white differentiation, which was suggestive of acute infarct. This is the axial cut NCCT head soft tissue window. On the left is the normal image showing no obvious hyperdense area in the region of basilar artery, whereas on the right is the image of our case in which we can see hyperdense basilar artery sign, which is likely suggestive of thrombus in the basilar artery. So to confirm the thrombus in the basilar artery, CT brain neck angio was done while the patient was in the CT suite itself. This is the cine image of the normal case in which we can see the basilar artery normally opacified and further dividing into bilateral PCA. Whereas on the right is the cine image of our case in which we can see basilar artery ascending upwards, and then there is sudden cutoff of the basilar artery here, and then further the P1 segment is also not opacified of the bilateral posterior cerebellar arteries. So this is a volume rendered image of the CT brain neck angio. On the left is the normal CT brain neck angio, where we can see bilateral vertebral arteries combining to form basilar artery and then further dividing into bilateral PCAs. Whereas on the right is the image of our case in which we can see there is sudden cutoff of the bilateral P1 segment of PCA and basilar artery top, which is suggestive of thrombus in the top of basilar artery and P1 segment of bilateral PCA. So combining the finding of NCCT head and CT brain angio, the final diagnosis was made, which was hyperacute right cerebellar infarct with distal basilar artery thrombotic occlusion. Now may I request Dr. Pavni to take the case discussion forward.
Thank you, Dr. Shobhit. So in view of the findings of NCCT head and CT angiography, the final diagnosis of the patient was an acute ischemic posterior circulation stroke with large vessel occlusion involving the distal basilar artery. So mechanistically, we see three broad patterns of basilar artery occlusion, which are pure embolic occlusion, in situ thrombotic occlusions, and tandem lesions. And in view of the CT angiography findings in our patient, pure embolic basilar artery occlusion was the most likely cause. Before I move forward, in this case, I would like to reiterate the concept of a penumbra. In an acute ischemic stroke, tissue injury consists of an irreversibly infarcted core, which is surrounded by an ischemic penumbra that is functionally impaired but potentially salvageable. Reperfusion therapy aims to rapidly restore blood to this penumbra, thereby limiting the infarct volume, preserving neuronal function, and improving the clinical outcome. So I would like to emphasize that the concept of time is brain is basically time is penumbra, and we are trying to salvage the penumbra in our case. After diagnosing the patient as having acute ischemic stroke, we counseled the patient's family regarding the further management, which included the reperfusion therapies. And as per the guidelines, intravenous thrombolysis was administered within the therapeutic window. In our patient, tenecteplase in a dose of 0.25 mg per kg was given within 90 minutes of the symptom onset. Crucially, thrombolysis was not treated as the treatment endpoint. Given the presence of a large vessel occlusion and based on evidence from the attention and the Baucher trials, early parallel planning for endovascular therapy was initiated, and the attendants were again counseled by the neurointervention team for mechanical thrombectomy. This video demonstrates endovascular mechanical thrombectomy for large vessel occlusion. We see that a large thrombus has been formed in the large vessel. So vascular access is obtained via the femoral artery and a guiding catheter is navigated into the large vessel, and then under the fluoroscopic guidance a microcatheter and microwire is further advanced across the vessel, following which a stent retriever is deployed across the thrombus and is then gently withdrawn, retrieving the clot and restoring the blood flow. So mechanical thrombectomy offers a rapid and effective reperfusion treatment option with higher rates of functional recovery, reduced infarct volume and reduced mortality. And if achieved in the first pass, a shorter procedure time with low procedural risk. So coming back to our case, after taking a written and informed consent of the procedure from the patient's attendants, the patient was shifted to the cath lab at around 1:45 a.m. Groin puncture was done at 2 a.m. and after the puncture of the right femoral artery, the guiding catheter was taken into the left vertebral artery and a DSA angiogram was performed, which showed complete occlusion of distal basilar artery with no antegrade flow. Subsequently, an aspiration catheter and a stent retriever were also taken for mechanical thrombectomy. And as seen in the picture, this was the clot which was retrieved in the first pass within 12 minutes. Controlled angiogram showed complete recanalization of the basilar artery with distal antegrade flow, a Tiki-3 flow, which is a predictor of good functional outcome. This procedure was performed within 12 minutes of groin puncture. So in basilar artery occlusion, early and complete reperfusion is the single most important determinant of survival, and in this case, timely mechanical thrombectomy proved decisive. This consolidated timeline demonstrates how each critical time target was achieved with complete revascularization within 2.5 hours of the symptom onset. So then our patient was shifted back to the MICU. He was on mechanical ventilator under sedation. His sedation was switched off at around 8:30 a.m. on 2nd of November. 8 hours post EVT, he started responding to commands with a GCS of E4-VT M6. He was extubated around 16 hours after the EVT. He had mild deficits in the form of right cerebellar ataxia. On the third day, he was shifted to the ward and his rehabilitation was started and was discharged 7 days later with a GCS of E4-V5-M6, which is a full GCS. So this further reinstates clinical implication of timely reperfusion. Because of early and complete recanalization, brainstem involvement was negligible and a good collateral circulation was achieved. This pattern strongly predicts a favorable functional outcome, reinforcing the principle that rapid, coordinated reperfusion therapy can dramatically alter prognosis even in the most lethal forms of stroke. This is the patient's testimonial.
इनका नाम मुकेश चौधरी है, ये भरतपुर से बिलोंग करते हैं। इनको पहले 28 तारीख को अटैक आया था, फिर हम यहाँ महात्मा गांधी हॉस्पिटल लेके आए इनको, तो राजीव शर्मा सर के निर्देशन में इनका अटैक का इलाज हुआ है। यहाँ छल्ले डले हुए इनके, फिर यहाँ 2 दिन रहने के बाद इनको पैरालिसिस हुआ था। यहाँ 2 ब्लॉकेज निकले थे इनके, जो बलवीन सर और MM गुप्ता, मदन मोहन गुप्ता सर के द्वारा रात को 3 बजे वो ब्लॉकेज खोल दिए गए। फिर ये 3 दिन ICU में रहे। ICU में रहने के बाद इनको बाढ़ में शिफ्ट कर दिया गया है। बाढ़ में शिफ्ट करने के बाद 5 दिन बाद इनको छुट्टी दे दी गई। आज इनकी हालत बिल्कुल सही है, ये चल फिर सकते हैं, बिल्कुल सही है और बिल्कुल कोई दिक्कत नहीं है इनको, ये सो भी सकते हैं।
Now I would like to call Dr. Madan Mohan sir to take the case forward.
So thank you, Dr. Pavni. Now I would like to share few matters about the review of literature. So this is the recent randomized clinical trial in the acute basilar artery occlusion. Previously, attention trial and Boucher trials has been shown. So it is clearly showing in the 2024 that the endovascular thrombectomy at 1 year compared with the 90 days was sustainable for favorable MRS score 0 to 3. We are dealing with the modified ranking score 0 to 3 means it is functionally independent patient or minimal support is needed to live a life. 0 to 3 is our achievable point in any reperfusion therapy. So clinical outcome in this study was 44.6% in the arm of thrombectomy and 19%, which is much more double. You can see with the graph that the proportion of the patient, around 39% proportion is get good outcome with the thrombectomy. Only 10 to 18%, it means double the patients will get the benefit with the thrombectomy, and that is literally around half of the control group. So now what is the advantage which I was telling? So one case which we have done after the installation of this cath lab, the case was very complex. It was referred from other hospital. Everything was done, but referred to us because we are having the biplane and a good infrastructure. So this was a case of 74-year-old female and who had subarachnoid hemorrhage due to ruptured aneurysm, and she had multiple right ICA aneurysms. So this was the CT scan which showed the subarachnoid hemorrhage in the basal cistern as well as the sylvian fissure. This was his CT angiography, which was not clear. So after that we did the 3D rotational angiography, which is very important to decide the treatment. This is the ICA multiple segments. So this is the view of the 3D. You can see one aneurysm over here in the near the ophthalmic artery. This is a giant aneurysm around 25 mm, and third aneurysm is this one. This was the ruptured. Those three aneurysms were situated at the right internal carotid artery, and all three has to be taken simultaneously. It was very challenging because this middle aneurysm doesn't have any neck. It was incorporating by all the vessels, so we don't have the entry and exit from it. So these are the depictions: that's one aneurysm, two aneurysm, and three aneurysm. So what we did, we don't know where is the ending and when is the exit actually. So this is the anterior posterior view, means we are looking from the front, and this is the lateral view, we are looking from the side. So front and side were simultaneously working, and we are navigating our wire through this aneurysm in both the plane, and we have to protect this aneurysm as well, because during the navigation if it perforates, patient can die on table. So this is the advantage, and you can see how the simultaneously this wire was looping around, and fortunately we were able to navigate this wire distal to this one simultaneously into the lateral plane also. So it is not possible in the single plane because we don't know where we are going, and if this wire will go into the different position and ultimately we and after that we have placed our stent, decanalize or to reconstruct the neck, because we don't have neck over here, and we have placed one stent in the both the things. So you can see this is the flow diverter stent which we have deployed from this artery to the across the neck of the aneurysm till the first aneurysm, and after that we have placed the coils within the aneurysm simultaneously, and after completion of treatment of this aneurysm we navigated our wire distal to this aneurysm which was ruptured actually, and we placed the stent over here, and through the navigation we completed the coiling for this aneurysm. So all the three aneurysms were taken care with this aneurysm with the stent and coil, flow diverter and coiling over here, and flow diverter for the proximal. So all the three aneurysm in the right internal carotid artery is treated in this patient. This was the control angiogram, and this was the post-procedure CT scan, and this was the patient who walked down on the day of the discharge without any deficiency. She is elderly lady, so surgical point of view, sir knows that it is 3 aneurysms in one side with the multiple comorbidities. Surgical challenging is there. I want to thank neuroanesthesia team who has supported tremendously this case, because it was a long procedure, around 3 hours, and everything went well. So our future plan is that we have to make MGUMST at a very dedicated stroke center, which we are already here, but we want to make that it should be known by anyone in the Rajasthan that they can get benefit from this institute. Anybody get a stroke, then the 24/7 stroke team is available in the Mahatma Gandhi Hospital, with the help of the team of neurology, neurosurgery, neuroanesthesia, emergency, critical care, and radiology. Without teamwork, it is not possible. And it will be Rajasthan's first dedicated advanced neurointervention center, and as DM program I told before also in the interventional radiology. So why it is future? Because neurointervention directly saves the neuron. This is time is brain, time is penumbra, and time is neuron actually. So explosion of the evidence and indications shows that this is now standard of care, especially in the acute ischemic stroke and hemorrhagic stroke in the aneurysms. It is minimally invasive, maximally effective, and precision medicines in real time, and it needs integration of the neurology, radiology, and the neurosurgery. It's a teamwork, and with the AI, we will make its shape future again. Thank you, management of MGUMST, for giving me immense support, and grateful, and collaborating with Department Neurology, Neurosurgery, Neuroanesthesia, Emergency, Radiology, and CCR Review Committee, and Patient Committee. Thank you very much.